Ma'am, please start.
Good evening, everybody. On behalf of Maha IIP Women Committee, myself, Dr. Jayashree Shivalkar, welcome you all for this program today, Thursday Thrills, which is a flagship program of Women's Committee. Through this program, we try to reach out to general pediatricians with the topics of their interest. Few years back, there was a time when there was a specific protocol for vaccination, which was mostly done in first 5 years and few vaccines till 10 years. But now it has extended up to adolescents vaccination and up to adults also. And though we have protocols, there are many incidences which go out of this protocol, and there are a lot of queries in the mind of pediatricians. So today we are here and we are extremely fortunate to have vaccine expert Dr. Sanjay Marathe with us, who is going to guide all of us. And I sincerely thank Dr. Ujjwala Gowri and Dr. Sushruta Deshmukh for completely planning this program, coordinating and bringing in front of you today. So thank you all of you. Now to start the program, I think Dr. Sanjay Pakmode and Dr. Amol Pawar, President and Secretary, are busy. So I invite Dr. Sanjay Deshmukh, Convener Maha IIP, for his words of address.
Good evening. I'm extremely sorry. I'm preoccupied with another meeting, but it was an opportunity for me to welcome you all for this activity. Since last 5 days, our dynamic women committee is conducting awareness talks on various issues in adolescence for the teachers, staffs, parents. And today on Thursday Thrill, we have very important topic which they are going to discuss is on adolescent vaccinations. And today it is a privilege to have our Women Committee Executive Board members, Dr. Ujjwala Gowri Madam and Dr. Deshmukh Madam, who are discussing adolescent vaccinations. And what we can ask more when we have experts like our own vaccine samrat, Dr. Sanjay Marathe sir, to guide us. So thank you, Dr. Marathe sir, and my best wishes for this program. Thank you. Thank you very much. And welcome all faculties. Thank you, madam. Over to Jaya, madam.
Yes. Thank you, sir. Bringing together a vast topic like vaccination, that to adolescents, it is not very easy. And I know Dr. Ujjwala and Dr. Sushruta has really researched this topic since last 8-10 days. They have prepared their presentations and they have come out with some very important questions for Dr. Marathe. And we all are eager to listen to it. So I invite Dr. Sushruta Deshmukh. She is a consultant pediatrician at KEM Pune and 2-3 other places also she is visiting. She is EB member of Maha IIP and she is EB member of Pune IIP also, PG convener also, and she is a national trainer for fever module of IIP. So over to you, Sushruta madam, to take the program forward and introduce our chief guest and other speaker. Thank you.
Thank you so much, Jaya madam, and giving us the opportunity. And I've seen you work so much throughout the year, and you have been actually at the helm steering the ship of Women's Committee at the Maharashtra IIP level. So I have not seen so much passion and zest in the work which you do. So I appreciate all.
Thank you.
On behalf of both of us, I thank you so much for giving us this opportunity. And we felt that there was a need to cover adolescent vaccination, which is often, it's put on the back burner. So we thought of taking up this topic. So today's session, we have an expert. We have Dr. Sanjay Marathe as our expert over here. So Dr. Ujwala, will you please start sharing the screen? I can just. Okay. So Dr. Sanjay Marathe is MD DNB, he is Chairman Scientific Committee Respicon 2025. And most important, which I felt from his CV was that he is the ACVIP West Zone member 2021 in 2020 and 2021. So we are proudly privileged to have none other than the doyen of vaccination to guide us here and to answer our queries which a general pediatrician faces. Sir has been a chairman and scientific committee Pedicon 2018, president IIP Nagpur in 2005, and guest speaker for national and state conferences. And there is a lot which can go on about him, but for want of time, I would proceed and talk about the program, in which the first talk will be delivered by Dr. Ujwala Gauri on the adolescent vaccines, that is Tdap and human papilloma virus, followed by my talk, which will be on catch up in the adolescence, and followed by an expert, ask the expert session, where it will be a charcha on the frequently encountered cases which we see in our practice. So Dr. Ujwala Gauri is MD Pediatrics and DCH Mumbai, and she's AP at Bharati Vidyapit Medical College and Hospital Sangli. She's consultant pediatrician and neonatologist and director of Ashirwad Maternity and Children Hospital at Sangli. She is a West Zone EB member, Maha AP Women Committee in 2025, and she is the IAP certified BLS instructor, treasurer of IAP Sangli City branch. So I invite Dr. Ujwala Gauri to take her first talk. Ma'am, you unmute yourself. Ujwala, please unmute yourself.
Ujwala madam, we can't hear you.
Yes, you can start.
Yeah. Good evening, everyone, and it's a pleasure. And thanks to Sushruta for that kind introduction. And it's a great pleasure to share this platform with great stalwart like Dr. Sanjay Marathe and Dr. Sushruta. And I want to especially thank Jaya ma'am for giving me this opportunity on this Maha AP Women's Wing platform to talk on child and adolescent for this Child and Adolescent Healthcare Week 2025. Today's topic, adolescent vaccination and vaccine on time, teens are prime. This was coined very specifically by Dr. Sanjay Marathe sir, and it focuses on one of the most crucial yet often overlooked aspects of preventive pediatrics. With the increasing school and college interactions, peer influences, and travel, there is a need for the adolescent immunization to go stronger. So through today's session, we aim to refresh our understanding on catch-up schedules, special situations, and also practical approaches to adolescent vaccination. And we are privileged here to be with the experts. We'll also share our, clear our queries. So let's strengthen our commitment to the theme, strong foundations and healthy futures. So today's learning objectives will be that we'll be understanding why adolescence is a key immunization opportunity, and also review on the AIP and ACVIP adolescent vaccine recommendations, and also dive immunogenicity and the practical tips which we are going to see. So what is the importance of this adolescent vaccination? We know adolescence carries a age group of missed childhood vaccinations. So introduction of adolescent specific vaccines. So we know that the immunization protects not only against vaccine preventable disease, but also prevents the spread of certain infections within the community, and therefore promotes the healthy growth of the adolescents. So it's our duty to protect the youth, which is the nation's future. So what is the need for this adolescent vaccination is that the immunity which has waned of the childhood vaccines like measles, pertussis, tetanus, and diphtheria, this has to be boosted up. So that's the need for adolescent vaccination. Besides this, to protect against certain diseases which have a higher mortality like varicella, hepatitis A. So we need to immunize for that, and also prevent vaccine preventable illnesses that emerge specifically in adolescent, like the human papilloma virus related cancers. Then we have to protect adolescents prior to the exposure. So before a sexual debut, the HPV vaccine is a necessity. And as it's the vaccine preventable disease elimination program, like the MR campaign, the congenital rubella syndrome. So that's why we have to be a part and let the adolescent get immunized with these specific vaccines. And also it's a catch up who have missed the previous vaccines, like some of the children who have not taken the basic vaccines. It is time that it is in the adolescent that we catch up these vaccines. For students who are going to plan to travel and study abroad, it's a necessity that there are specific vaccines which Dr. Sushruta will be emphasizing on. And this is the way the program of adolescent vaccine has to be planned. They have less routine contact. The adolescents have a less routine contact with the health services, and they have missed boosters and catch-up opportunities. So adolescence is now not too late, rather a key window where each adolescent visit should be taken as an opportunity, and we have to vaccinate the children. Now, what about the burden in India? There is a high burden of the cervical cancer and HPV-related disease in India, substantial and preventable morbidity and mortality. So we are specifically going to emphasize on HPV and Tdap, and the national programs which are being introduced are mostly for the early childhood. But now, since the HPV and the Tdap campaigns have been launched, it is going to be little better. So the adolescent age group is we have all seen the adolescent age group is a critical window for vaccination and prevent adult disease, to reduce the transmission and fill the immunity gaps. Now, what about the safety and the immunogenicity? All these vaccines which are given in the adolescents are safe. They have mild reactogenicity and can be tolerated well. We can co-administer it with other vaccines, specifically if they are given at different sites along with different syringes, and we have to check the leaflets for their different instructions. The immunogenicity in the adolescent age group is quite robust because of the mature immune system. So they take up the vaccines also well. We know that the HPV vaccine has an efficacy of more than 90% for preventing cervical cancers. So it is necessary that we promote and motivate the adolescents for these vaccines. The Tdap and the TD boosters also restores the protection which has waned from the childhood, that is specifically again pertussis, which is again resurging globally. So, to summarize, adolescence is a crucial second chance to close the immunity gap and add the protection. Now, what are the checklist, adolescent vaccine checklist? We have to take opportunities of all the school health camps, the college camps, sports events, and also the adolescent friendly health service OPDs, and involve the school and college authorities in motivating and getting these camps and arranging vaccination for these adolescents. We have to ask for the immunization card and see if the child has missed any previous doses, so that the booster doses can be given. The catch-up vaccinations for MMR, varicella, hepatitis A, B, and typhoid have to be planned. And if an adolescent is again traveling abroad or during an outbreak of certain diseases like influenza, and there are some certain chronic diseases like hepatitis A, B, we have to risk assess, and then we have to plan the vaccination programs. Each adolescent which comes to us during the OPD days, we have to educate them as well as the parents, because sometimes the parent is hesitant, has some fears, has some myths in them. So we have to discuss regarding these cancer prevention and schedule the program of vaccination and address their hesitancy with good interviewing and promote them the facts. It is necessary to take consent vaccines and document these vaccines which are given, so that it can be a documentation for their future purposes. So it is necessary that each pediatrician turns each adolescent clinic visit into a vaccine opportunity. Now, what happens is, why is there hesitancy? Because there is lack of awareness among the parents and adolescents. Sometimes it is they feel it is costly. And so we have to use strong language for recommendation that this vaccine will protect your child and it will take him or her into a safe adulthood. So these myths have to be addressed, and the safety has to be reinforced, so that we provide a adolescent friendly environment which gives them a clear message that vaccination is a must. And these the pediatricians should be consistent upon the message, so that the the adolescents are motivated. Now, when we are talking about these vaccines for the adolescents, they can be considered into 4 groups. The first one is the exclusive adolescent vaccine, that is the Tdap and HPV. Next is the catch-up vaccines like MMR, hepatitis A, hepatitis B, varicella, typhoid, and the typhoid conjugate vaccine. And the third group is vaccine for adolescent in special situations, like if there is an influenza outbreak, when there is pneumococcal vaccines to be given, JE vaccine, rabies, and meningococcal. And for adolescents who are going to travel for studies or other purpose, vaccines like meningococcal, yellow fever, again Japanese encephalitis, and rabies. So these are the 4 groups, and of these I'm going to talk more on the exclusive adolescent vaccines, Tdap and HPV. So looking at the HPV, human papilloma virus vaccine, it prevents HPV vaccines before HPV infection before exposure, and the cervical, the anal, the oropharyngeal cancers, and the genital warts before the sexual debut. So how do we administer this? This vaccine is given to both girls as well as boys who are 9 to 14 years of age. 2 doses are given. Today, if it is given today, one is given after 6 months. So 2 doses are given. But if a 9-valent vaccine is to be administered, it is given at 0, 6, and after 1 year. Now, this is for age group between 9 to 14 for boys and girls, 2 doses. But if the boy or a girl is, if an adolescent is more than 15 years of age or is immunocompromised, then 3 doses are given at 0, 1, and 6 months, depending on the vaccine which is given. In India, we have Cervarix and Gardasil. Gardasil is available in 2 forms, Gardasil 4, and that is quadrivalent, and nanovalent, that is 9-valent, and is approved in India. We can change, that is interchangeability can be done, but following local product guidance if we are going to switch over from one brand to the other. This HPV vaccine can be co-administered with other vaccine, and it is safe, and though it is not recommended during pregnancy, and there is no need for HPV testing before vaccination. So we all have to make HPV a must-discuss vaccine for adolescent when they are entering the clinic. So this is regarding HPV vaccine. Regarding Tdap and TD booster, Tdap and TD boosters, it prevents diphtheria, pertussis, and tetanus in adolescents, and also reduces the transmission of pertussis to the infants. So pertussis in immunity. Now, what is the need for giving this Tdap? Because the immunity has waned from the childhood, and it starts from 4 to 13 years. So once the immunity has waned, it's necessary to give this booster. According to the IAP and the ACVIP schedule, Tdap is given at 10 to 12 years, and TD is given at 16 to 18 years. So TD booster is to be given every 10 years after the initial Tdap, and mostly Tdap is preferred over TD for the first adolescent booster. So these are the targets which we have to achieve, and adolescent should be viewed as an active immunization target and not just a passive recipient. And the key vaccines of HPV and Tdap are high impact in adolescent age group. So we have to review each visit of these adolescents, educate them, vaccinate them, document them, and recall them for the further vaccinations. So friends, let's commit every adolescent visit as a vaccine checkpoint and be the vaccine champion for the adolescents. So my references for today's talk was on IAP guidelines on immunization, the fourth edition 2022 and 23, and IAP immunization recommendation update 2024, and the ACVIP website and schedule. So with this, I finish with the essential vaccines, and now we move on to the vaccines during outbreaks and the
Ujjwala,
other
can I
vaccines which are
Ujjwala,
required for
can I comment
adolescents
for a minute?
to boost up.
Dr. Ujjwala, can
Yes,
I?
sir. Yes, yes,
An
sure.
excellent talk, Dr.
Yes, sir.
Ujjwala, excellent talk. You have covered all the
Yes,
topics.
sir.
You have covered all the points, and the need of the HPV vaccination, that is so important. Only two major changes from the slides which you have shown. In an Gardasil 9, you have said 0, 6 and 12. That is not correct.
Yes.
It should be 0, 6.
Okay, sir.
2 doses, 0, 6 for both.
Okay. And more than 15 years, there are 3 doses.
Yes. So, and
More than
0,
3 doses.
at present 0, 1
More than
oblique,
15 years, 3 doses.
yeah, and that 0, 1 oblique 2, that one was basically for the Cervarix, which is not available by the GST.
Right, right, sir.
So now
Right.
it is 0 to 6 only. And secondly, what we
Okay.
should say, now the vaccines are available from 9 to 26 years
Okay.
as a gender neutral.
Yes, sir.
So in the boys as well as girls, the vaccine is available from 9 years to 26 years.
Okay. Okay, sir.
Yeah.
Shall I
Otherwise,
move ahead?
Yeah. Otherwise, excellent.
Okay, sir. Now we move on to our next speaker, Dr. Sushruta Deshmukh, and it's a pleasure to introduce her. She's a consultant pediatrician at KEM Hospital, Pune, and Surya Hospital, and Kulkarni Children's Clinic at Somwarpet, Pune. She's a treasurer for IAP 2023 and a core committee member of IAP Pune from the last 8 years. And she's also a PG clinic convener for IAP Pune 2024 to 2026 and an EB member of MAHA-IAP Women's Committee of from the West Zone for 2025. She's also a national trainer for fever modules. So over to Dr. Sushruta.
Yeah, so
Dr. Sushruta, you can screen share now.
Yeah, so thank you, Dr. Ujjwala, for this kind introduction, and I will start my presentation and I will. Yeah, so is it visible now?
Make it full screen. Yeah.
Yes, just maximize it.
Yeah, it's maximized actually. I can see full screen.
Yeah.
Okay, done.
Okay, so thank you, and I'm as Dr. Ujjwala has already covered the adolescent vaccine, which is Tdap and HPV. I would like to move ahead with catch-up vaccination. And catch-up vaccination is of paramount importance because of, as you rightly said, gaining immunity to all the vaccines which are administered when the child is young. And secondly, we all know that the morbidity of the disease, if it happens in an adolescent age group or an adult age group, is much more severe than that which could happen when the child suffers from an infection. So there is an extreme important need to go ahead with adolescent vaccination. So what is the need basically for vaccination? So as per the National Family Health Survey, which was conducted in 2015, almost 60% belonging to the age group of 12 to 23 months are fully immunized. So we have a huge gap of about 40% in the 12 to 23 months who are not immunized. And there is a lot of heterogeneity in the state and district level vaccination. Like Pondicherry has a very high rate of vaccination, with around 90% vaccinated in this age group, as against the northeastern states where you have an abysmally low 30% level of vaccination. So extrapolating this data tells us about the likelihood of adolescents being unimmunized or partially immunized. Plus, there is a higher risk of vaccine preventable disease in the adolescent age group because they are very mobile. They keep moving from one place to another, frequent travelers also, and they mingle in a lot of community groups. Now there is a high teenage pregnancy rate, so the need for catch up in immunizations. And we should also know that vaccination protects the pregnant. When you vaccinate a pregnant woman, it protects the pregnant woman as well as the newborn from the vaccine preventable disease. This especially applies to pertussis, where immunizing the mother with a Tdap booster in pregnancy will protect a young neonate from acquiring pertussis. So now going to the Indian Academy of Pediatrics ACPIP Advisory Committee on Vaccines and Immunization Practices has given the following recommendations in adolescents for catch-up. So as Dr. Ujjwala has already highlighted, HP, just sorry, I think, yeah. So as she's already spoken about HPV and Tdap, I'm not be speaking much about them. So the other vaccines which are also included in the catch-up would be MMR vaccine. Now the importance of MMR vaccine is the main aim is to eradicate congenital rubella syndrome, which could happen when the female contracts rubella during her pregnancy. So MMR vaccine is recommended as 2 doses at 4 to 8 weeks interval. However, if the person has received at least one dose of MMR vaccine prior, then 1 dose only needs to be given. So 2 doses are required only if absolutely no doses of MMR have been received in the past. Hepatitis B, as we all know, 3 doses, 0, 1, and 6 months. This protects the adolescent as well as if it's a female, it will also protect the newborn by preventing vertical transmission of hepatitis B during pregnancy by having robust hepatitis B titers. Hepatitis A, 2 doses recommended at 0 and 6 months. But here there is a caveat in the sense, India being endemic, around 50% of our adolescents beyond the age of 10 years are generally must have had subclinical hepatitis A infection, and hence sometimes it may be prudent to check for their anti-HIV IgG titers to see whether they are seroconverted and then go ahead with 2 doses. Typhoid conjugate vaccine, single dose recommended right up to 45 years of age. And chickenpox, again, the morbidity, as we know, is more in the adolescent and adult age group. So 2 doses of varicella vaccine, which is a live vaccine, spaced at 4 to 8 week intervals. And as Dr. Ujjwala said, HPV, which is a gender neutral vaccine, to be given between ages 9 to 14 to boys as well as girls as a 2-dose schedule at 0 and 6 months, and those between 15 and 26 years of age as a 3-dose schedule of 0, 2, and 6 months. So these are the vaccines other than the vaccines which are for the adolescents, like Tdap and your HPV vaccine. There are also some special situations where the following vaccines, some vaccines will be recommended not to all adolescents, but special situations like some adolescents bearing certain health conditions, such as heart disease or congenital heart disease or a valvular heart disease, pulmonary disease like a cystic fibrosis or an interstitial lung disease where the lungs need to be protected. If the child has primary immunodeficiency. Also, those needing splenectomy, either emergency splenectomy or planned splenectomy for hematological conditions. Here, the splenic opsonization function is lost, and hence they need to be protected against encapsulated organisms such as Hib and pneumococcal vaccine and meningococcal. And also those who would need treatment which causes immunosuppression, such as maybe a post chemotherapy for a malignancy, or somebody on collateral vascular disease requiring steroids, or somebody who received rituximab, or a nephrotic syndrome who has been put onto steroids for minimal change disease. So here, only in these special situations, we have recommendations by the ACVIP in addition to the vaccines mentioned previously. So here, influenza would be of paramount importance because the mortality could be high here. Influenza, a single dose every year is recommended. JE only in endemic areas. One thing has to be remembered is the outermost limit for JE catch-up is 15 years. So 2 doses need to be given only in endemic areas. Now, more or less most of our cities in India have become endemic for JE. Hence, the prudence in giving JE vaccine as a 2-dose schedule in catch-up also. And special vaccine like pneumococcal, where maximum 2 doses can be given 5 years apart, and rabies vaccine. I will be talking about pneumococcal vaccine later. So now going ahead with the reasons for inadequate vaccination in adolescents is primarily lack of knowledge amongst the caregivers as well as the general public about the importance of adolescent vaccination. We also don't have special adolescent vaccination programs as against those which are available for children up to 10 years of age. Also, the behavioral attitude of the adolescents matters. They are more carefree and they would not probably be following parental advice or even the doctor's advice. We don't have special adolescent clinics where the child, sometimes the adolescent feels embarrassed to attend it in a pediatrician's place, as well as they don't feel that they're old enough to go to an adult physician for vaccination. So we lack that contact with the patient, contact with the adolescent to catch him and complete his catch-up vaccination. And like I said, fewer encounters with the healthcare system because they really do not fall in so often. So we lose that window of opportunity. And like Dr. Ujjwala said, it's better to catch them whenever they come, even for the mild illness, and to emphasize the importance of vaccination and vaccinating. So the ACVIP gives us the outer limits for catch-up vaccination. Tdap, the outer limit is 11 to 12 years, 1 dose, and even if the child comes after between 13 to 18 years of age, 1 dose of Tdap should be given if no Tdap has been received prior. HPV is already talked about. MMR, 2 doses, 4 weeks apart till 18 years of age. Hepatitis B, 016 till 18 years of age. Hepatitis A, either killed or a live vaccine. Live vaccine, single dose. Killed vaccine, 2 doses, spaced at 0 and 6 months. The second dose could be 6 to 12 months after the first dose. Chickenpox, 2 doses, 4 to 8 weeks apart. Typhoid conjugate, single dose, outer age limit here regarding as adolescents is 18, but can be given up to 45 years of age. Influenza only in special situations till 18 years of age, single annual dose. JE, 2 doses, 4 weeks apart. Outer age limit for JE is 15 years of age. And pneumococcal and meningococcal in special situations, which I'll talk about in the subsequent slides. So basically, pneumococcal vaccines are not required to be given to children after 6 years of age because the chances of invasive pneumococcal disease go low. However, they will be indicated in special high-risk cases such as those having anatomical or functional osteomia secondary to hemolytic anemias, or secondarily HIV, or those who are immunocompromised, or even those who have a CSF leak. So basically, these children are prone to get infections because of encapsulated organism, hence the need for pneumococcal vaccine. So always 1 dose of PCV has to be given as a primer before giving PTSD because the response to PTSD will not be robust unless it is given before, even after a conjugate vaccine, that also 8 weeks apart. And PCV, PPSV 23, another dose is recommended only 5 years after the first PPSV 23. And those two only in anatomic or functional osteomia or immunocompromised condition. Otherwise, by and large, PCV 1 single dose 8 weeks later by PPSV 23 should be enough. And lastly, meningococcal vaccines, they are not at all recommended routinely. Only in special situations they would be recommended, especially in outbreaks or international travelers or those children who go abroad for higher studies or even those visiting Hajj. Asplenia, complement deficiencies because meningococcal vaccines, meningococcus affects those having complement deficiencies and also those who are on complement blockers such as eculizumab or students going abroad for studies. If it's a healthy adolescent, you follow the regular immunization schedule of 2 doses, first dose at 11 to 12 years and another booster at 16 years. At those only with this much is enough for a healthy adolescent. However, if he has underlying comorbid conditions or risk factors, only then would boosters of meningococcal vaccine be required every 5 years. So to sum it up, the percentage of adolescent vaccination is abysmally low in India and hence the need to give them vaccination. Adolescents need to be protected against vaccine preventable disease due to high incidence of severity. Vaccination protects the adolescents and also provides herd protection by protecting the infants and the children. There is a need for catch-up vaccination for those who have missed prior doses, so catch them young. And sensitization of parents and doctors towards adolescent vaccination is of paramount importance and crucial to the successful running of an adolescent vaccination program. So with this, I thank you for a patient listening. And I hand over to Dr. Ujjwala. Sir, if you would like to add something here.
Excellent talk, Dr. Sushruta. You have covered almost everything and the importance of the catch-up vaccination. The only point which you have said in meningococcal, that is the CDC recommendation at 11 and 12 years and 15 to 16. In our country, we do not have such recommendations. Our recommendation that meningococcal vaccine, quadrivalent meningococcal vaccine, can be given after 2 years of age for both the vaccines which are available. But for Menectra, we can give it from 9 months. 9 months of age, and second can be given after the age of 1 year. So 2 doses are recommended for the Menectra, whereas for the second GSK vaccine, only single dose after the age of 2 years. And that too, not a routinely, should be given only in an high-risk situation.
Yes, sir, but here I was just talking about adolescent vaccines.
So in adolescents, we do not give MCQ like this 11, that is the CDC guidelines. In America, because if you study, they have got their surveillance studies, which says the maximum stress of meningococcal disease is at that adolescent age. So they give 1 dose at 10 to 11 years, and second booster after 5 years, say, which comes around 15 to 16 years. And now, if you see in the students' vaccination schedule, those who are visiting from our country to USA, they will say if your child is above 22 years, meningococcal vaccine is not required. Something like that.
Okay, thank you so much.
Ujjwala, please unmute.
Ujjwala, unmute. Ujjwala, unmute. Ujjwala, unmute yourself.
Yes.
Go ahead.
So we move on to the next session of today's talk. Ask the experts. So we have, as Dr. Deshmukh has very prominently explained, we have the Samrat of vaccine, Dr. Sanjay Marathe, who is going to solve our queries. So moving on to the first question on TD vaccine. If there is a 10-year-old child has received TD as a booster, do you need to administer Tdap as well? And if so, what is the interval, sir?
Very nice question, Dr. Ujjwala. See, we must understand one thing, that we have to protect adolescent from the pertussis. And here the TD has been given. If you see the initial recommendation,
Yes,
they will say wait for 5 years. Then there was another recommendations to wait for 2 years. And now, because we want to protect an adolescent against the pertussis, because very rightly Sushruta and you have said, there is a significant waning of immunity, whether it's a natural infection or a vaccine.
great.
So by the age of 10 to 11 years, the individual protection against the pertussis has gone. So now the
Yes.
recommendation is, you do not have to wait for any time interval. If unfortunately you have given a TD, you can give Tdap at any time. And that should be considered as
Okay.
an Tdap booster for an adolescent. So that now
Okay.
the interval has gone. Suppose today I have given TD, tomorrow I
Okay.
can give Tdap.
Okay.
Because Tdap is so important to
Okay.
me.
Okay. Yeah, because it covers both diphtheria as
It
well as
basically covers
pertussis.
pertussis. Pertussis is the biggest problem.
Pertussis.
And maximum
Right,
cases
which
of
is
pertussis will be
research.
seen after 6 years or in the adolescent, and they are the biggest reservoir for the spread of the disease. Either
Right.
to
Yeah.
the immunocompromised people, or those having weak immunity, or the infants who are not protected.
To other
The infants who are not protected, because the
people
infants,
who
they
are
will start getting
not
vaccination from the 6
not
weeks.
immunized. Yes.
And they have got the maximum mortality and morbidity if an infant less than 2 months gets the pertussis.
Right. Okay. Okay. Shall we move to the next question? If a 11-year-old child inadvertently received wholesale pertussis DPT or Tdap, What next? Can it be considered as a valid 10-year booster dose?
See, basically, we are worried about DTWP and DTAP full dose in an adolescent is the risk of reactogenicity, not immunogenicity.
Yes.
Immunogenicity will be adequate, very good. But I am more worried
Yes.
about the reactogenicity. Therefore, what we recommend
Right.
after the age of 7 years, if you want to give any DPT vaccine, it should be Tdap, rather DTAP. So, full dose of tetanus and low dose of pertussis and diphtheria.
Okay.
So if it has been
Diphtheria.
given, nothing wrong will happen
Okay.
except the reactogenicity. So it is considered as a valid dose.
Okay.
Only thing you will have to explain to the relative that patient might get some local reactions on a higher side, may have got fever and all that, which can be very well managed with the help of paracetamol. And nothing else is
Okay.
required.
Yes.
If I extend this
Okay.
query, the boosters, suppose unfortunately, a Tdap, a low dose of diphtheria and pertussis is given as a booster at 18 months and 5 years. The guideline says still it is considered as valid if this is given in the
Okay.
first or the second booster less than 5 years. But do not encourage of giving Tdap at the age of 18 months and 5 years. But unfortunately, if it is given,
Okay.
is considered as valid. But if you give this Tdap as a
Valid.
primary dose, then it is invalid.
Okay.
Is it clear?
Meaning, sir,
Okay,
even
sir.
if we give a
Yeah.
advertently if we give it at 18
We'll
or
move on to the next question.
Yeah.
Ujjwala, just 1 minute. Meaning,
Yeah.
A child has
even if we give at
a
18,
child has received the Tdap booster at 9 years instead of 5 years booster. Then when we give the next TD or Tdap?
So it should be very clear in our mind that suppose the 5 year booster was not given and the patient has come to you for say wound management and you thought that this is a good opportunity to give him a Tdap
Okay.
so that he is protected against all. So the guideline says
Okay.
if this kind of an Tdap is given till the age of 9 years, the repeat dose of Tdap should be given at the age of 12 years. Okay. Which we normally give it at 10 years. Here you have given it at the age of 9 years. So you will repeat one more dose at the age of 12 years and then you will continue TD subsequently. But suppose this Tdap is given at the age of
TD
10
can be
years.
given after what is the gap?
Usually 10 years, but we recommend at 16 years. The reasons are programmatic, not because of this very scientific reason, but more of a programmatic.
Right.
That a pediatric patient is not going to come to us again after the age of 16 years. So we try to give him an additional booster at the age of 16. But if this Tdap is given at 10 years, then 12 years Tdap is not required.
Yes. Okay. Okay, sir. Okay. A completely unimmunized child comes for vaccination at 11 years of age. So what is preferred? Tdap, TD, or Tdap, Tdap? And if, then why?
Very, very interesting story behind this question. In 2010, I was moderating one session and all experts were there. And I said, scientifically speaking, it should be Tdap and not Tdap, TD. But because at that time we had no adequate information whether more doses of Tdap can be given at this age. So CDC, everybody was saying at least give one followed by TD. But if you read the CDC guidelines and the explanation, what they have said, some people have unknowingly has given Tdap 016.
Okay.
But still nothing has went wrong. But subsequently what will happen? So whether you give Tdap, TD, 016 will be the schedule as a catch-up vaccination. Not 6 weeks, 10 weeks, 14 weeks. The schedule for the catch-up vaccination in an unimmunized child will be 016. So one dose at day 1, that is day 0, then TD at 1 month, and another TD at the age of after 5 months. So 016 is the schedule.
Okay.
So either you can use TDAP, 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 or TDAP, TD, TD, they are equally. So
Okay.
you can go for the either of the schedules.
Okay.
But the
Okay.
schedule must be very clear, 016. Because the last dose acts as a booster.
So, yeah, what will we prefer at 18 years of age? Booster, TD or TDAP, sir, then?
It depends on if the person has not received TDAP till the
Like
age of
suppose if
18
there is
years.
a girl who has who is 18 years, who is pregnant now, and she's already received a vaccine at TD at 10 years. So what do we give?
No, you have opened a very different question. First, I will answer this question, and then I will go for the pregnancy.
Okay.
If
Okay.
an individual who is 18 years old, and if the vaccination history says that that girl or a boy has never received a TDAP, which she was or he was supposed to take it at 10 years, then that child
Okay.
must be given TDAP.
Okay.
If the child has received TDAP at the age of 10 years or 11 years as a booster, now she has come at 18 years, you can give TD.
Okay.
Suppose now she is pregnant,
And a pregnancy, yes.
irrespective of the previous TDAP vaccination, every pregnancy,
Yes.
we will give 1 dose of TDAP for protection of mother as well as a new infant up to the age of 3 to
In
4 or 6
fetus.
months,
Yeah.
where we want to protect that individual from tetanus and we want to protect that child against pertussis. So every
Okay.
pregnancy will be giving 1 dose of TDAP.
Okay. Okay, sir. Okay. So what is the rationale for immunization with TDAP at 10 years?
It's an excellent question. As we have already discussed, there is a natural waning of immunity by the primary and the booster doses which you have given. Even after a natural infection of pertussis, there is a significant waning at the age of 10 years or 11 years. So what you are creating, that you are protecting an individual till the age of 10 years, and now an unprotected community is growing as an adolescent. So we must protect them. So tetanus protection will also require for another 10 years if I give TDAP at the age of 10 years. So for that is tetanus. If you see, India has reported maximum cases of pertussis and diphtheria all over the world, and they are maximum from the adolescent age group. So adolescent will be protected against pertussis, they will be protected against tetanus, and they will be protected against diphtheria, for which they were initially protected adequately till the age of 10 years. The another advantage that is adolescents, they behave very differently for the pertussis. They will never come to you as an typical pertussis symptoms and signs or a whooping cough.
Right.
They will come as non-responding cough for 2 weeks, 3 weeks.
Okay.
And they are the biggest reservoir for spreading the disease to the unprotected.
Okay.
So we do not want that spread to occur and the disease to continue or the circulate in the country. So what we require is to protect against this adolescent and extend the protection.
Okay. Okay, sir. So can we give can we give TDAP, HPV and MMR together?
Yes, HPV, TDAP and MMR can be given together because two are killed vaccine, one is live vaccine.
One is
So you
live.
can give any number of live vaccine on the same day. You can give any number of killed and live vaccine on the same day. But if you want to give 2 live vaccines, then it should be gap of minimum 1 month.
Okay. Okay, sir.
Otherwise, you can give the same day any number of vaccines.
Okay, sir. Moving on to the HPV vaccine, if the HPV related cancers are usually seen in the 4th and 5th decade of life, then what is the need to administer this HPV vaccine so early in adolescence?
See, the point is for which you must understand what is the HPV disease and what are the late problems of the HPV infection. The vaccine which is given is not against the cervical cancer or any other cancer. The vaccine which is given is against the HPV infection. And this HPV infection is responsible for the different cancers and the high risk groups causing cancers or genital warts and all that.
Yes, sir.
So before in a naive population, when they are not exposed, before they are exposed to the HPV virus, we must give them the protection. That is one. Secondly,
Okay.
the pediatricians are known to give good vaccines to your pediatric patients. So all pediatric patients will come to you to take the vaccines. They believe in pediatricians more than any other doctor.
True.
The third important thing is that the immune responses are excellent. So if you compare the immune responses in the age group of 9 to 14 and 15 to 26 and 26 onwards, the best antibody response is seen in the age group of 9 to 14.
Okay. Yeah, that's why that
Fourth-
age group.
Correct. And the fourth advantage is the cost. You have to give only 2 doses and not the 3 doses. So all advantages
need to-
if we give between the age of 9 to 14
Early. Yeah.
early. So catch them early, protect them early, and prevent them from all the possible complications. Secondly,
Yeah, true.
genital warts will be seen within say 3 to 4 years of exposure to HPV.
Yes.
So once they will have this exposure, then if you will give vaccine, the vaccine efficacy may not be the same.
True.
So you are giving a compromised vaccine efficacy for a person who was already exposed to the HPV. And
Yes.
we have n number of studies which says this is the best period, the immunogenicity is excellent, and the protection is same as the vaccine is given after the age of 50.
Okay, sir. Why has ACVP not recommended single dose HPV?
See, for that, you should understand the WHO has said single dose HPV is going to be a game changer.
Okay.
But WHO will always say what is good for the community. What is going to be an overall impact if this HPV is given in your national immunization program. Okay. So for WHO, they want to bring down cervical cancer cases to the minimum by 2030.
Yes. Okay.
So what is the intervention they have suggested? A single dose. Okay. Where we as an pediatrician protecting an individual, we give it as a gender neutral vaccine. So if you will go and see all the studies which are based on the for the single dose HPV, they are in the girls, not in the boys.
Okay.
Then secondly, we are not very sure whether we have got the long-term immunogenicity available with the single dose as compared to the 2 doses and 3 doses. In some of the studies, the antibody titers were less.
Oh, yes.
Then in like Kinsey studies or South African studies or even Indian studies, secondly, what they have seen that their aim was what is the efficacy against the persistent HPV infection, not against the precancerous conditions and all that in all, or antibody titers.
Okay.
So what will happen? Suppose tomorrow we start talking about a single dose, which is usually happening with some Rotarians and all that. They will conduct the programs at the different schools and they will give 1 dose. Then the community will be confused. Dr. Ujjwala says get 2 vaccines. Some Rotarian camps they say give 1 vaccine.
One.
Then you never know. They will never mention what kind of an vaccine has been given.
Right.
So, and it is not a gender neutral vaccine. So should we give it to the boy also? We
It has
cannot
to
give
be
it to a
given.
boy. So at present, single dose HPV vaccine is suffering a programmatic, scientific, and lack of evidence for the long-term protection. So the ACVIP says we do not recommend single dose vaccine to boys as well as girls because there are no studies. At present, for the individual protection, we still go with the same 2 doses between 9 to 14, 3 doses from 15 years
Yes.
onwards. But tomorrow, suppose Government of India introduces this single dose vaccine, then it will be a good idea that 80% of the boys and girls will be protected against, or say 90% of the population will be covered with at least one dose, which is going to break the spread of the infection.
Right.
Suppose everybody gets an HPV vaccine, boy as well as a girl. It is going to break the transmission cycle, and that will have a biggest
Okay.
impact in the community.
Mhm.
So excellent idea as a single dose in a national immunization program with coverage more than 90%.
But it should be implemented.
In a national immunization
Right.
program, not to an
Sir,
individual.
a 10. Right.
So
Sir,
do
a
not
10-year-old
encourage,
girl
do
child
not
has
encourage
received the
camps.
first dose. So we'll
Yeah.
move to the next question.
Yeah,
A 10-year-old girl has received her first dose of HPV on 10th of October and the
Yes.
second on 6th of February. So is the second dose considered valid? And if it is not, then when will you repeat the invalid dose?
See, Ujjwala, you have only covered HPV and you have said 2 doses are required 6 months apart.
Yes,
Okay. So if you calculate from the 10th of October,
10th October.
November, December,
Feb-
January, February, March, April. Ideally,
February.
this child should be given second dose after
Second
the
dose.
10th of April.
Okay.
So still this is invalid. But what is the minimum interval acceptable between 2 doses is 5 months.
5 weeks. Okay.
5 months. Still it is invalid.
5 months.
5 months. So still it is invalid. So this second dose is invalid. So the recommendation says consider this as a second dose and go for a 3-dose schedule.
Okay.
Because you have given this dose without a gap of minimum 5 months. So
Yes.
consider this as a second dose, which was supposed to be
Okay.
given at 2 months interval. You have given it at 4 months interval. No harm.
4 months.
Give one more dose, either after 3
Okay.
weeks, these 3 months. Minimum gap between second dose and the third dose should be of 12 weeks.
12 weeks. Okay.
So I can give after 12 weeks, the third dose I can give you. Or if I want to maintain only a gap of 5 months or 6 months, at the end of the 5 months from the first dose, I can give the second.
Okay.
So either or I can finish it as a 3-dose schedule.
So 3-day schedule,
Or I consider this as invalid and I give a valid second dose by keeping a minimum gap of 5 months between the first dose and the last dose.
Okay. Okay, sir. So moving on to the next question, I'll request Dr. Sushruta to take these questions.
Yes,
Dr.
sir.
Sushruta?
Yes. So basically, the questions on Tdap and HPV mostly are covered. If we have some time at the end, I'll just take a rapid fire questions on Tdap and HPV, which Dr. Ujjwala has sent it to me. So now moving ahead with the other vaccines. So now, is there a need to give hepatitis A vaccine to a teen in an endemic country like India? And because most of almost 50% of our population is already having subclinical hepatitis A. So do we need to give hepatitis A because the morbidity is high in the adolescent, or we need to check their titers? And if yes, should we give it upfront, hepatitis A directly, or should we do his HIV, IgG levels? And if they're positive, then that means he's infected and don't give it. That was the first part of the question. And I'll ask you the next one later.
If you read the ACVIP recommendation about 2 years back, it's written in ACVIP recommendation. After the age of 10 years, suppose somebody has come for an hepatitis A, go for the anti-HIV IgG levels. And for hepatitis A, immune correlate of protection is 20 micrograms per ml.
Yes.
For hepatitis B, it is 10 micrograms.
10,
For hepatitis A, it is 20.
20.
So,
Okay.
and the one thing we should always remember, the India has moved from high endemicity to intermediate endemicity. So you can say a good number of people are not exposed to hepatitis A, whether it's a subclinical or anecteric hepatitis, which is very safe in first 5 years and has been protected for lifelong. So hepatitis A vaccination is very important, because if you'll read recently, many cases of acute viral hepatitis going for the hepatic failure and subsequently for the transplant, significant number of cases are from the hepatitis A, which initially we used to say hepatitis A will rarely require a transplant. And it is very easy to protect a person from hepatitis A with the changing lifestyle and what kind of food we eat. All of us must be protected. If the family was quite concerned about the hygiene and all that, and the child was never exposed to the unhygienic food, after say 10-15 years, suddenly is exposed to all unhygienic food like pani puris and all stalls and all that, he goes out with his friends. And if he gets hepatitis A in the second decade, he is likely to get a very bad hepatitis. This is one part. So hepatitis A is a very important one. Should we go for the IgG, HAV levels? See, suppose it costs you about say 1500 rupees. There are a possibility that 50% the report might be above 20, 50% it is less 20. So the recent discussion and all they say, you may not go for the IgA, HAV levels. You can just give vaccine and finish it off. So you are very sure that you have protected that individual. Nothing wrong is going to happen. Suppose you give additional doses of hepatitis. This is the practical answer to your query. Now
Yes,
the
sir.
last question, live or killed?
Yeah, live or killed, yeah.
They are both equally good. For the live, you have to give only 1 dose. And for a killed, you have to give 2 doses. Always remember, in hepatitis A killed vaccination, the gap should be of 6 months, not less than 6 months, not 28 weeks also. The gap between 2 doses must be 6 months, calendar year. You can give either, whatever you like.
So
Both are
just,
equally good.
so just to summarize what you said, sir, there is
Yeah.
definitely a need to give hepatitis A vaccine to a
Absolutely.
teen because the mortality is high and they
Yeah.
could go into fulminant hepatic failure. Secondly,
Absolutely.
is irrespective of doing the titers, it's wise to go upfront because it will be cost effective also. And if live or killed can be given equally immunogenic and efficient, live single dose, killed 2 doses, first dose and second dose at least 6 months after the first dose and in the window period of 6 to 12 months, but not earlier than 6 months. Am I right? Yes.
Yeah.
Now, sir, next one, if an adolescent has already suffered from typhoid, he's been admitted for typhoid, so he's probably immune to typhoid, should we still give him a TCV now? And is there a low role of TCV booster?
I will answer your first question.
Ah.
As all of us know, TCV infection does not give you protection. It does not work like a vaccine. So the person who has suffered from typhoid is not protected against typhoid like a typhoid conjugate vaccine which is given. So this child who had typhoid, that means he was not protected before also. Therefore, he got the typhoid. So as soon as he recovers from typhoid, you have to give 1 dose of typhoid conjugate vaccine. Is it clear?
Yes.
In initial
So
references,
after
you
what
might
is the
see.
interval?
Yes.
So
I
what
was
is the
about to-
interval from the
I was-
infection and the vaccine?
I was about to tell you the same. Some
Okay, sorry,
recommendations
sir.
they used to say wait for 1 month. So this is all arbitrary. You may wait for 10 days if the patient has recovered from typhoid. He is normal, he has started eating and all that. He has started going to the school. You can give conjugate typhoid vaccine even on day 15 also.
Okay.
And so the other part of it was our boosters recommended since there could be waning or inoculum effect secondary to heavy eating of Panipuri heavily infested with typhoid. So are the titers sufficient to protect immunity after one dose, or are boosters advocated?
If you believe in the studies which are available, now we have got about 7 to 8 years data from the primary studies. And in that study, both the arms were studied, 6 months to 2 years onwards. And what they have seen, the antibody titers are persisting about the fourfold rise, even at the end of 7 years. And the population 2 years and above, they are doing exceptionally well, most probably because of the subclinical typhoid exposure to them, which is acting like a booster. 6 months to 2 years, still they are behaving fairly well. Their antibody titers are about the fourfold rise. Okay. And another study what they have done, they have given a booster and they have seen what happened. So they have compared a population after a booster and the population which has not received a booster. With the booster effect, the antibody titers have gone very high, but it has come down again to the same level in next 1 or 2 years. So only that high antibody titers were there for 1 year, and after second and third year, again it has come down to the same level in which the unboosterized population was compared. So they said there was no much difference in a boosted and non-boosted population. They are the same. So at present, we have no evidence to say that the booster should be given.
Clear enough.
So
Thank
still we give 1 dose.
Okay.
Next question. Yeah, Dr. Ujjwala, can you go to the next slide?
Yeah.
Yeah, so which now generally ACIP recommends flu vaccine till 5 years of age because the mortality of with flu or the severity is less after 5 years. So which adolescents would you recommend to receive flu booster, and up to what age should annual flu boosters be given to such children?
Flu can be given from 6 months to 100 years. Anybody can be given.
Hmm.
So minimum age is 6 months. Maximum age is till the person is alive.
Hmm.
If you study the recommendation in the Western world, they give flu to every child every day. Even for the adults they give, for the older people they give. But country like ours, with 140 crore population, it is practically impossible to give flu vaccine. So what they have seen, which population should be protected on the priority. So WHO has given the prioritized program. Who should be protected on a priority? So first they say 2 extreme ages. Less than 5 years, above 60 years. This population should be given flu every year. Then second, pregnant women. Then healthcare workers. Then policemen. Those who will come in contact with the crowds, like police, army people, those working in the corporations, healthcare workers, everybody should be given a flu vaccine because they are going to come in contact with the crowd and likely to get flu. Now there are special situations where they should say a chronically ill person, an immunocompromised individual. So which is this population? Person with chronic lung disease, person with the chronic persistent asthma on the steroids, chronic kidney disease, chronic heart disease, HIV patients. These patients are likely to get bad flu infection. So for them, there is no age limit. As long as they are at a risk, we should give them flu vaccine. And the best period to give flu vaccine is beginning of your rainy season. Because the maximum circulation will be there in the rainy season and in the winter season. And on an average, a flu vaccine protects you for about 8 months. So give vaccine just 15 days before the rainy season and protect your child from maximum circulation of flu, that is from the rainy season and the winter. This is the scientific basis where.
Yes, yes, excellent. Pushna, next one. So there is this adolescent who's come to my clinic and he's 18 and he's got admission in BJ Medical College. So now he wants to protect himself against the vaccine, the disease which he will encounter in the wards. So what should I be recommending to such an adolescent?
Sushruta, this is a very good question, and we have never discussed this question in our vaccinology updates also anytime. But this I find it very interesting that all the students who are going for their first MBBS should have the counseling with the adolescent doctors. It's an excellent question, and I personally feel an adolescent who has got the admission in MBBS, we must go through his vaccination schedule, what he has received. We must recommend him in all catch-up vaccination. But on a priority, which vaccine I will suggest to one person, because he is going to come in contact with n number of patients in next 10 years, 20 years, 50 years. And I want that this person must be protected before he is exposed. So first thing which I will see is first immunization chart. What he has received, what he has not. The documentation, not from the history from the parents. On top of it, I will say hepatitis B will be the first priority in my mind. If there is no documentation, what I will do, if there is a history that he has received some doses, I will see to that what is anti-HBs titer in this person. If it is less than 10, I might give him one booster and repeat it after 1 month to see what is the response. Because seroconversion has to be demonstrated in all the medical students. So this is very important. So my priority will be 3 doses of hepatitis B, then 2 doses of hepatitis A if he is less than 18 years. Then I will select whether I have to use 720 or 1440. The strength of the 2 doses remains the same. So hepatitis B remains my priority. Then I will be interested in protecting him against the chickenpox. Because chickenpox in the second, third decade can be very severe, lots of complications. And there is every chance that he will be exposed to a chickenpox patient. Then I will protect this child from 2 doses by MMR, by giving MMR 2 doses, if he has not received 2 doses after the age of 1 year. So MMR becomes my priority, chickenpox becomes my priority, hepatitis B, hepatitis A. Then I will see whether he has received Tdap. If not, I will give him 1 Tdap. Even I will recommend to give him pre-exposure prophylaxis for rabies. Because he is also again at the risk of exposure to the rabies, and you never know, he will be working in the PSCs and all that, where he is likely to get with the dog bite or something. So it is always better to protect medical health workers with the pre-exposure prophylaxis. The other diseases, I am not that much worried. I will give 1 dose of typhoid conjugate vaccine if he has not received. If he moves to the hostel, eating the food from outside and all that, so typhoid becomes a very important vaccine for me. This was suddenly I realized that this many vaccines I should cover. Other vaccine becomes flu and all that. Flu vaccine is still a good idea. You can give every yearly 1 dose of the flu vaccine. Then I think we have covered JE and all that. It is not indicated, so JE I will not consider.
Yes.
Meningococcal vaccine is an optional vaccine, so I will not think.
Meningococcal.
It becomes an optional vaccine, so I will not suggest meningococcal vaccine to a medical student.
And since he's going to be entering college quickly, any number of live vaccines can be given on 1 day. Any live and killed can be given on 1 day. And if 2 live have to be given, then either on the same day or
Or
4 weeks apart.
Keep a gap of 4 weeks.
Yes, and any interval between live and killed is also fine, and any
Yes.
interval between 2 respective killed vaccines is also fine. It can be
Absolutely. This should be your, you can say, mantra.
Yeah,
mantra of vaccination.
because he's
All of us must know this.
so he's joining college quickly, so we maybe want to vaccinate him.
Yes. You
Yes.
can finish it off within 1 month period.
Yes. Yes.
So call and give maximum vaccine. Go on giving the killed vaccine throughout the month. And suppose some live vaccines are remaining, you can give it at the end of 1 month. Like
Only,
chickenpox can be given with the gap of 1 month. Whereas less than 13 years, we give the gap of 3 months.
only different sites or areas between the two vaccines should be ideally at least an inch or so, right?
If you are giving on the same limb, you can give it at the other limbs. Two different limbs.
Okay, thank you, sir.
Two
Excellent.
different sites.
Yeah.
And
Lots of clarity here. Thank you. And the next one?
yeah, it's already splashed.
Okay, yes. So now this child is, the adolescent is traveling abroad for his studies. What vaccines would you recommend to this traveler?
I think this,
You already-
everybody must be facing this issue. There are two aspects of this. They will come and say, sir, हम तो तुम्हारे ही patients है, certify कर दो.
Yes, it does
That is
happen,
wrong.
sir.
But that is wrong.
Especially.
I never do it. Because we must inform the parents that your child is going abroad and you never know what kind of an infection is likely to get there. And if he is
Hmm.
unprotected, he might have a serious disease there.
Hmm.
So for the visa point of view, if you want a certificate, it's a different story. But you must complete the vaccination and go. So most of the universities will ask for 3 or 4 vaccines. They will say whether the child has received 2 doses of MMR after the age of 1 year.
MMR. Yes.
Then they will ask whether chickenpox 2 doses have been given or an history of disease. Then they will ask 1 dose of meningococcal vaccine, quadrivalent.
Yes.
Usually less than 22 years. After 22 years, they will say it is not recommended. Then they will ask you to get an IGRA test. This
Yes.
IGRA test is basically for the tuberculosis.
Hmm.
If it comes positive, then we'll have to get an X-ray test done. If the IGRA is negative, they will not ask for the X-ray test also. But at the same time, you should see to it that hepatitis B is covered, hepatitis A is covered, and suppose he is going to the countries where it is endemic for yellow fever, then we
Yes,
might suggest
yellow
him to
fever.
take yellow fever because that becomes a mandatory vaccine in that age. Suppose somebody is going to Kenya for the studies, and Kenya wants yellow fever vaccine, which is a mandatory thing there. So we'll have to give yellow fever vaccine. The good part about the yellow fever vaccine is now you have to take only 1 dose for lifelong protection. Initially, it was for 10 years. Now, 1 dose of yellow fever vaccine gives you lifelong protection. So, on a priority, MMR 2 doses, chickenpox 2 doses, 1 dose of meningococcal vaccine, and an IGRA test. In 95% of the students, they will ask only these questions. But it is our responsibility to go through his vaccination card, suggest him all other vaccines, give the vaccine, protect an individual and allow him to go.
Right. Yes. So, sir, this is a 10-year-old boy who's diagnosed with nephrotic syndrome and he still is following into the category of minimal chain nephrotic syndrome, finished his 6 weeks course of 2 mg per kg of steroid and now he's shifted to alternate day of 1.5 milligram per kg per day on alternate days. So basically he has to be given his pending vaccine is Tdap vaccine as well as chickenpox vaccine and he's on alternate day steroids. So how should I wait? Should I give him upfront or one being a live vaccine and one being a killed vaccine? So what proforma should be followed by for such a child?
First, we should ask him when the doctor has stopped his full dose steroids. What is the date? That is the first question I will ask. For example, today is 13th of November. And suppose this patient has come to you and he has stopped his full dose steroids on the 8th. The schedule will be different for our vaccination. So there should be a gap of 4 weeks from the date on which the full dose of steroids have been stopped. Then only I can give live vaccine. This is very clear. Second thing which I should make it very clear for all the audiences, that the full dose means 2 milligram per kilogram per day, maximum up to 20. That means up to the weight of 10 kg. After that, the dose is 20 milligram per kilogram per day, irrespective of the weight. So that is full dose. So somebody is taking it for more than 2 weeks, full dose, he is considered as immunosuppressed or compromised. This child, we cannot give any live vaccine. We can give live vaccine to this child after 4 weeks of stopping full dose. So varicella will be given after 4 weeks of the last full dose, day of the full dose. As far as the Tdap is concerned, which is a killed vaccine, can be given at any time. Immune responses might be compromised to some level, but still Tdap can be given irrespective of his full dose. Second question which you have asked, the alternate day steroid is not an contraindication. Intra-articular steroid is not an contraindication. Inhaled corticosteroid is not an contraindication. Application of the steroid containing ointment is not an contraindication. So the only contraindication is full dose, 2 milligram per kilogram per day of a prednisolone, even for 2 weeks, is an contraindication. I think
For a live vaccine.
it answers all your queries about the steroids.
Yes. So the last one is Tdap. If we are given him when he's on alternate day steroid, his immune response could be suboptimal. Do we still hold it as a valid dose or better to
Yeah, it is considered as well.
Okay, even if it's suboptimal, you are
Yes.
okay with it. And you
May
don't-
not be suboptimal. I'm not saying suboptimal. Might be relatively less as compared to an other people.
Okay, so we don't repeat one more Tdap
The
later.
protection remains the same.
Thank you so much for so much clarity on all the questions.
It's a pleasure.
You know, so much of pearls we have learned from you.
Always a pleasure.
Yeah. Thank you. I think we are towards the end of the program, and on behalf of Team MahaAP 2025, it's my pleasure to propose the vote of thanks for today's session under the banner of Child and Adolescent Healthcare. So first and foremost, I express my sincere gratitude to our respected MahaAP President, Dr. Sanjay Pakmore sir, and Honorary Secretary, Dr. Amol Pawar sir, for their constant guidance, encouragement, and support in organizing such meaningful academic activities. And also a heartfelt thanks to our dynamic chairperson of MahaAP Women's Committee, Dr. Jayashree Shivalkar ma'am, for her excellent coordination and leadership in making today's program a grand success. We extend our warm support, warm appreciation to our expert speaker, Dr. Sanjay Marathe sir, for sharing his vast experience and deep insights on adolescent vaccination. Truly enriching, sir, and thought-provoking. Special thanks to Dr. Sushruta Deshmukh for her informative and encouraging presentations. And our gratitude also goes to Mrs. Pallavi and the entire support staff for their seamless technical and logistical support behind this, who are behind the scenes but just supporting us. Last but not the least, a big thank you to all of you participants who have joined us online in this evening and contributed to the success. So let us all wind up this saying that we continue working together to ensure strong foundations and healthy futures for every child and adolescent. Thank you all.
Thank you, sir. And
Thank
it
you
was
all.
Thank you so much for this wonderful academic interaction.
both of you. Yes. Thank you so much.
Thank you and good night.
So fine, उज्ज्वला व्यवस्थित झालं. I mean, no issues.
हो,
right?
छान झालं. आणि जरा झाला 20 मिनिटं उशीर झाला पण anyway we covered most of the questions and sir also gave reply to patiently to all of them.
And you covered quite a bit.
Okay, thank you. Bye. Good night.
Nice interacting with you.
Yes,
Bye.
yes,
Bye,
yes,
Jayashree
yes.
Madam. Thank you so much.
Right. Pallavi madam, thank you. Thank you so much. There were no questions in the chat box, I think, so it was okay.
There were no questions. No. Chalo, then let's leave.